Well, thank you very much for having me, and thanks to everybody who's joined us today. I'm just going to start sharing my slides. You see that now? Great. So I'm going to talk today about synthesizing evidence about harms in systematic reviews, and first want to acknowledge a few sources of funding. I've received support from a number of different places, and a lot of the work today that I'm going to speak about was supported by the Patient-Centered Outcomes Research Institute, PCORI, in the US, on a project which Kay Dickerson was the PI for, and a number of other great members of that team were involved, including Tianjing Li, who's now at Colorado, and Riaz Qureshi, who's also at the University of Colorado, Denver. So the premise that I want us to think about a little bit today is whether including harms in systematic reviews could be doing more harm than good. And I think that might be the case for a couple of different reasons. One is that harms reporting in primary studies is suboptimal. And as I'll discuss, it's suboptimal in a couple of ways. Reporting is biased in primary studies because we use selection criteria to decide which harms are going to be reported. And evidence is missing and inconsistent across different study reports. And that's one of the things that we found in the MUD study, which I'll talk about in some detail today, that when you compare different reports about the same study, you get a different picture of what harms occurred. And then the second reason that I think harms in systematic reviews might be doing more harm than good is that the methods that we use in systematic reviews are themselves unreliable. So compared with the way that we assess benefits, assessing harms requires different evidence, it requires a different skill set, and it requires different methods of synthesis. And it's not clear that reviewers understand harms reporting and harms analysis in the way that they understand benefits reporting and analysis, or that they not always have the skills to do that. Or that they have the data to do that from primary studies. Additionally, harms may be related to interventions, to particular drugs or particular surgeries or medical products, rather than to the health problems that are being treated. So we typically organize systematic reviews around people who have a particular kind of health problem, as well as the interventions that we're interested in using for that. And that might not be a sensible way to organize reviews about harms if the kinds of harms that occur across different groups of people using those interventions for different particular health problems. So let's start off by thinking about how harms are reported in primary studies and clinical trials. Here's an example from a paper that discussed a number of different problems in harms reporting. And one of the quotations in this paper is that most patients had an acceptable adverse event profile. And that's a really curious thing to say about harms or adverse events, because we wouldn't say anything like this about benefits, and it's unclear what it means. There are a lot of different kinds of adverse events, a lot of different kinds of harms. So which particular adverse events or harms are we talking about here? And what does it mean to be acceptable? Does that mean that it was acceptable to the regulator, to FDA, or that it was acceptable to the trialists, to the doctors who were involved in designing the study, or that they were acceptable to the patients? And if we're talking about the patients, are the same things important to a woman who is 20 years old as they are to a man who's 70 years old? People make different trade-offs. So we need more information about what kinds of outcomes occur in clinical trials. And that's true for harms as well as for potential benefits. But we tend to think about and tend to discuss harms using different kinds of language. And we would never accept this kind of language if we were talking about benefits. We also use different terms to discuss harms. And here's a few of the terms that are used from a paper that Riaz Qureshi led. Sometimes these terms mean the same thing. Sometimes they mean different things. And sometimes their meaning depends on the person who is speaking. So if you're using the term adverse event in a way that is consistent with the way that a regulator would use an adverse event, it's an unwanted effect that is not necessarily related to the intervention or the medical product that's being discussed in the report. Whereas a side effect, according to some users, is something that is causally related to the intervention that's being evaluated. So these terms are being used sometimes in very specific ways that are similar, and sometimes in very specific ways that are different. And sometimes, depending on the speaker, it's not exactly clear what the speaker means when they use these terms. And that's a problem when we're discussing potential harms. So I want to begin as we think about the way that harms are assessed and analyzed by making this distinction between systematic harms and most of the benefits that we assess in clinical trials and non-systematic harms. And this is a really important distinction in the way that these things are assessed and in the way that they're analyzed and discussed. So benefits and systematic harms are things that we tend to measure in the same way for all of the participants in a clinical trial. We select them a priori, so we define them in our study protocol and the trial registration, and then we analyze and we report those things using pre-specified methods. We'll have a statistical analysis plan, and we might deviate from that. We might use some exploratory methods at the end of the study, but we will also tend to use the methods that we laid out at the beginning. Non-systematic harms are things that are reported spontaneously by patients. They might be in response to open-ended questions. They might be things that are just mentioned during an interview with a doctor in the study. And non-systematic harms, because they haven't been laid out at the beginning of the study, may be reported based on the results. And that's a particular problem when we think about harms, because if we reported benefits based on the results, we'd refer to that as reporting bias or selective non-reporting bias. The methods for analysis and the reporting of non-systematic harms are often unclear in trial reports. They may not be specified very well even in trial protocols. So again, the reporting and the analysis may depend on the results and the observed data in a way that benefits and systematic harms don't. So when I talk about systematic assessment, let's use an example of a common measure of benefits. You might use a measure in a trial of psychosis, the positive and negative syndrome scale. And you can see the scale here on the left. You might, if you're developing a trial protocol, include a spirit figure, which is what you have here on the right. And if you're following reporting guidelines for a trial protocol, you would lay out when you're going to assess variables at baseline, when you're going to assess the outcomes after allocation and that closeout. And so you might have a table that looks like this with all of the different scales that you have, including in this example, the PANSS, the bands. For benefits, for things that we've specified at the beginning of the study, we typically report effect sizes and measures of precision. And you'll see different figures and tables with those data. So here you can see in a trial of aripiprazole for the treatment of psychosis, you can see measures of the total change from baseline. Here you've got a line figure on the left, where you have 0 change from baseline on treatment day 1, and then at each week following the beginning of the study, you have a measure for each of the treatment groups on that scale. And on the right, we have a figure showing another outcome in the same study, which is the proportion of patients who are very much or much improved on the clinical global impression of change improvement scale. And again, this is given at 8 days, 15 days, 22 days. So every week following the initial allocation and the first dose. By comparison, let's look at how adverse events or harms are reported in the same trial. So here in table 2, you can see treatment emergent adverse events that occurred in at least 2% of the treated patients in the safety population. So that's typically defined as people who have received at least 1 dose of the drug. And you can see a number of different things here that are reported. They're not in alphabetical order on the left. We'd have to figure out what order we think this table is even in. And it looks like they might be ordered according to the frequency in one of the groups, the center column, I think it is. But here we can see any treatment emergent adverse event on the top row, and then we can see a number of different treatment emergent adverse events that are defined in each of the subsequent rows. And on the right-hand side, we can see a bit of the text reporting. So there's some reporting of the different treatment emergent adverse events, and then we have some additional analyses, like the majority of all movement disorder episodes occurred before the second injection, generally within the first 3 weeks, when the patients in the treated groups were also receiving oral aripiprazole. So here we see an analysis which might make a lot of clinical sense. This might be an important analysis for a number of different reasons. It might help explain why some of these things are occurring. But we don't know, looking at this analysis, whether it was pre-specified. We don't know how many analyses like this were done and whether this was consistent with analyses of other adverse events. So the kind of reporting that we see here is is not like the reporting that we see for benefits. We don't have the same sort of structured data, structured reporting, structured assessment that we have about benefits. And as a systematic reviewer, that raises a lot of questions for me about what I should do with these data and how I might organize them and synthesize them with data from other studies. On the label or on the prescribing information that we have from the US Food and Drug Administration, we see a lot of different information about adverse events. And this is just one of different sources of information that we have about adverse events. Here we see information about things that occurred in lots of different clinical trials of people who are taking this for different uses. You can see here the indication for Aristada is for the treatment of schizophrenia, but for some drugs, we might see different indications there. We might see an indication for bipolar disorder, for example, for other antipsychotic drugs. And when we see different indications there, or when we know that the drug is used for different purposes, there might be information in the prescribing information that comes from trials and other kinds of studies that are done in those drugs across lots of different indications. So that may be different from the way that we organize systematic reviews. Now, the best practice when doing a systematic review is to use available evidence from all of the different available sources. But this takes us down a rabbit hole because there are a lot of different sources of information that we might have about clinical trials. There are public data sources, so we have letters that are written to editors, we have conference abstracts, we have journal articles, we have trial registries, we have reports by regulators like the FDA, but we also have European regulators, Japanese and Chinese regulators, and Australian regulators. We have non-public data sources, so we might have individual patient data, which are sometimes being made publicly available now through places like Vivli, but are oftentimes not accessible to the public. We might have grant proposals or study protocols, some of which are publicly available and some of which are not. Case report forms and memos. We might have emails and other correspondence about the trial. We might have unpublished manuscripts. So trying to synthesize information from all of these different data sources can be a really complicated and challenging task. So I'm going to tell you a bit of a story about the MUD study, which is the Multiple Data Sources and Systematic Review Study. This was funded by Pecori. Kay Dickerson was the PI, and there are a number of different contributors that I'll mention along the way. In 2 case studies, we looked at all of the different data sources that you have for clinical trials and the information that we get from those and what implications those different information sources would have for systematic reviews. So we included gabapentin for the treatment of neuropathic pain and quetiapine for the treatment of bipolar depression. We included parallel randomized clinical trials. We looked at only the placebo-controlled trials, and we limited this study to the double-blind studies where patients and the investigators were masked. One of the things we looked at in this study was how many different ways the outcomes were defined for benefits as well as for harms. So here you can see that there are different ways to define an outcome. And the outcome definition relies on all of the different choices that are made along the way here. So in this example from Deb Zarin and colleagues at the National Library of Medicine who created and maintained clinicaltrials.gov, if you're thinking about measuring anxiety, there are a number of different scales that you might use to measure that domain. So we have the domain anxiety, but we also have different scales or measurement tools like the Beck Anxiety Inventory, the Hamilton Anxiety Rating Scale, or the Fear Questionnaire. And for each of those different measurement tools or instruments, we can calculate a metric. We can calculate the value at the end of the study, or we could calculate the change from baseline, or we might look at the time to some event, like the amount of change, time to reach some amount of change, or for a dichotomous event, the time for the event to occur. And we might have different ways of aggregating the data. We could aggregate the data continuously using the mean or the median, or we could aggregate the data categorically. And if we're aggregating the data categorically, there are different ways in which we might set our cutoffs, proportion of patients with 50% improvement or 25% improvement, or we might have the proportion of patients who have some amount of decrease or improvement on the scale. So in the MUD study, we specified that we were interested in 4 different ways of assessing potential benefits of gabapentin. We looked at pain intensity, which was typically the primary outcome domain. We looked at quality of life, we looked at mood, and we looked at sleep disturbance. And we found in 21 different clinical trials, there were 214 different ways in which outcomes had been defined. We had 1,230 numerical results associated with those outcome definitions, but only 305 of those different results were publicly reported. So 75% of the results in this study for the four main outcome domains were missing. And we think that more data were hidden because we only had access to non-public data sources for 6 of the trials, which were trials that were done by the manufacturer that brought gabapentin to market. So for the 15 trials, which include things that were done by academics and that were not associated with non-public data sources like individual patient data or clinical study reports, which are the reports that manufacturers write for the regulators, we didn't have additional non-public data sources. So there might be even more missing information about this drug. A consequence of having all of this multiplicity in the individual trials is that it allows us, when we do systematic reviews, to cherry pick which results we want to include. And here you can see if we did meta-analyses for each of the different sources of information, all of the sources, just the journal articles, just the short reports, or just the reports to regulators, we could see a different distribution of possible meta-analyses using results from those sources. And I'm going to hone in here on the top part of this figure on the left, which includes the analyses using all of the available data sources. What we found in the MUD study was that we could do 34 trillion possible meta-analyses of the outcome domain pain, that is combinations using data from the same set of 21 trials. And if we zoom in on that a little bit here, you can see the dashed line on the right is the line of no effect. That is, there's no difference between the drug gabapentin and placebo. And the distribution that you see here is the distribution of possible meta-analytic effects. The kind of blurry bits below that distribution are chevrons, which represent the top and bottom of the 95% confidence intervals for each of those different meta-analytic effects. And what you can see here is that at the bottom, we've got the smallest possible effect, which is a small and not statistically significant difference between gabapentin and placebo. And on the left side, we see a large and statistically significant difference between gabapentin and placebo. It's interesting to me that these are non-overlapping confidence intervals. So these look like, if you put them in a forest plot next to each other, they look like they are two treatments that are differently effective or ineffective compared with placebo. Now, we can define harms in much the same way that we define benefits. So one of the side effects of quetiapine, or one of the harms associated with quetiapine, is that people tend to gain quite a lot of weight. And if you think about weight, you can put people on a scale at the beginning and at the end of the study, and you can measure how much they weigh at each of the time points. So you could calculate their weight, you could calculate their body mass index. And if you were looking at their weight, you might use their value at the beginning of the study or at the end of the study. You could calculate the change. If you were looking at the change, you might calculate it continuously or categorically. And just as we looked at benefits, you might define categorical change as a 7% increase, a 15% increase, 25% increase, et cetera. So because systematic harms can be defined, analyzed, and reported or underreported, much like benefits, we see the same sorts of problems here with systematic harms that we have for benefits. Now, articles, study registers, clinical study reports, individual patient data, and some other sources contain details about non-systematic harms as well. And this is a screenshot taken from Trials.gov for that trial of aripiprazole that I mentioned earlier. Here you can see the adverse events that occurred in at least 5% of participants that occurred in each of the different groups. And one of the things that you can see at the bottom of this is that clinicaltrials.gov tells us that the terms here come from the vocabulary MEDRA. Now, MEDRA, for those who aren't familiar with it, is a classification system for organizing information about harms in clinical trials. It's used by FDA and other regulators and has been in use now for over 20 years. This is a way of organizing information about non-systematic harms. At the lowest level, we have 70,000 plus lowest level entry terms. So these are things like feeling queasy, which is a way that a patient might describe to the doctor that they felt nauseous. And all of those different ways of expressing feeling queasy get grouped together at the lowest level that we use for analysis, which is called the preferred term. And then above the preferred term, we have different levels that can be used for analysis. We have the high level event term, high level term, which in this case would be nausea and vomiting symptoms. We have high level group term, like gastrointestinal signs and symptoms. And then we have a system organ class at the highest level of analysis, which is gastrointestinal disorders here. So at the top of this organizational system, we have 27 system organ classes. And as you can imagine, if we group things according to these higher levels of analysis, we can increase our statistical power in a clinical trial or another study. We can increase the chance that we see an important difference between a treatment group and a placebo group, for example. But we might disguise important differences in the different things that are occurring at the lower level. For example, if we were interested in people who had headaches, we might have some people reporting headache and some people reporting a migraine. Those would get grouped at the higher levels of analysis here, but they would be differentiated at the lower levels of analysis. And a headache is often very different in severity from a migraine. When somebody reports a migraine, it's often something that's more severe than when people report a headache. When we get that, we can see that when we analyze things at the lower level of analysis, but not at the higher level of analysis. Grouping in this way is common in non-public sources, but it's not very common in public sources. And it's also anecdotally common when we see reports from regulators like FDA. So in the trials of gabapentin, in the 15 trials that were reported publicly, only 2 of those reported harms or adverse events that were grouped, like nervous system or gastrointestinal system. 6 out of the 6 for which we had non-public data sources grouped those harms or those adverse events for analysis. For the studies of quetiapine that we looked at, none of those studies with public data sources or only public data sources grouped things for analysis, whereas 2 out of the 4 for which we had non-public data sources grouped things for analysis, like at the level of eye disorders, for which there was a difference between the treatment group and the placebo group. And some work that was done with Kay Dickerson, Nicole Fusco, Tianjing Li, and others, we looked at the reporting of non-systematic harms in various sources of information about quetiapine and gabapentin. And you can see here the studies for which we had both public data sources as well as non-public data sources. At the top here, you see the number of different adverse events. So this is not the number of events, but the number of different names given to adverse events that are reported in public and non-public data sources for each of the individual trials. You can see here at the top left that we have 7 different adverse events that are reported in the Baconia trial in public data sources, but 100 that are reported in non-public data sources. And the same pattern is seen for all of the other 5 trials. 2 in public sources, 102 in non-public sources. None that are reported in public sources, whereas 287 are reported in non-public sources. It's important too to see in the bottom figure, we see the same pattern, if not to the same degree, for serious adverse events. These are things that might require medical treatment or hospitalization. In the Baconia trial, none are reported in public data sources, but 8 can be found in non-public data sources. The same is true for the next trial. There are none reported in public sources, but 15 are reported in non-public data sources. One of the things that makes it so difficult to work with these as a systematic reviewer is that the harms that are actually reported in public data sources when they are reported using different selection criteria, often associated with these sorts of thresholds that you see here. So this is again an example from the trial of aripiprazole that I mentioned earlier. And you can see here 4 different sources of information about adverse events that occurred in this trial. The FDA snapshot is a source that is created with the patient in mind. So it's a summary on the FDA website in which you can see different adverse events, as well as different benefits that occurred in the trial. And here you can see that they've reported in the FDA snapshot events that occurred in at least 2% of the treated patients and had a greater incidence in the treated group compared with the placebo group. The prescribing information, which people often refer to as the drug label, includes information about events that occurred in at least 5% of the treated patients and were at least twice as common in the treated group compared with the placebo group. So a different numerical threshold as well as a different criteria for reporting the frequency or the difference in frequency between the groups. The trial registration on clinicaltrials.gov includes events that occurred in at least 5% of patients, and that's a threshold set by the authorizing legislation for clinicaltrials.gov. So that's one that's used on that website very commonly. And then in the journal article, you can actually see both of these sorts of thresholds being used. You can see in the text, we have treatment emergent adverse events that occurred in at least 5% of the patients. And then we can see in the same text, at least 5% of the patients and at least twice the frequency. And then in the table, which we saw earlier, you see events that occurred in at least 2% of the treated patients. So even depending where you look in the same article, you'll see different information about the adverse events. This has a number of different implications for synthesis. So here you can see a table from a trial of gabapentin, where you see information about dizziness, somnolence, headache, diarrhea, confusion, and nausea. But we can't tell just looking at this table whether the information was collected systematically or non-systematically, how many events occurred per person. This is just the number of people, I think, who had these adverse events. Whether they've also done the analyses grouped by different levels of synthesis, whether the reporting criteria have been applied here, whether these are above some certain threshold or difference between the groups, et cetera. We also don't know whether whether the definitions of these terms are consistent across sites within the trials, and definitions are consistent across trials that might be included in a review. So without more information about how these things are assessed, even when we add up the number of people who experienced somnolence or confusion, we might not know that those things have been defined in the same way across two different trials. So Riaz Qureshi led a bit of work and 3 papers that I'll discuss here about how systematic reviews of gabapentin use information about harms and report information about harms. And in that study, he included 70 systematic reviews of gabapentin, which we considered reliable. So those were reviews that met some minimum criteria for what we consider acceptable in terms of pre-specified outcomes, reliable search strategies that included a number of different databases, et cetera. And of those, most reported both benefits and harms, though some of the reviews were limited to harms only. In most of them, at least one harm was pre-specified, but in almost 40% of them, no harms were pre-specified as far as we could tell. Many of these reviews included randomized trials. In fact, almost all of them did. Some also included controlled clinical trials. Some included information from previous reviews, but less than 10% included information from observational studies, surveillance, registries, et cetera. And we found that no reviews searched the toxicology databases, regulators, or industry websites for additional information. What he found in this study was that review methods don't follow best practices. So I've already discussed how individual study reports use selection criteria like events that have to occur above a certain threshold, 5% or 2% of patients. What we found in this study was that reviews also add additional selection criteria, but in many of these cases, almost half of them, the selection criteria that are being used by the reviewers aren't clear. We couldn't discern what they were. In the ones that we could discern, we see that they included only adverse events that were reported in all included studies, only the most common adverse events listed, serious and common, and their common is defined as at least 10% incidence, which is a very high threshold compared with what's reported in many individual clinical trials, or only harms that were statistically significantly different between groups, which is very problematic, of course, because most studies are not powered or designed to test statistically significant differences between treatment groups and placebo groups when it comes to harms. Many of the studies included a meta-analysis for at least one harm, but many of these meta-analyses don't report what rare event assumptions are used. They don't report how they handled missing data. And missing data when you're looking at harms in systematic reviews might be missing for the individual patients in the studies, but it might also be missing for an entire study. And in that case, it may not be clear whether it's missing because the harm didn't occur or didn't occur frequently enough to have been included in the review, et cetera. And those have different implications for the types of missingness that we might be dealing with. Particularly if it's being if it's missing in a way that is not at random. That is, it's informative missingness. It's related to the outcome. When we look at reviews of the same drug, that is gabapentin, we find that reviews of the same drug report different harms. What you can see here on the top with the highlighting in red around the different events are reactions that are reported on the drug label, so in the prescribing information, which include dizziness and somnolence and peripheral edema. For studies of epilepsy, we see somnolence and dizziness and ataxia and fatigue. And for young people, we see a number of different harms as well. So you can see here that a number of the things that are reported in trials and reported in reviews are also reported on the drug label. And you can see on the bottom of this bar chart the things that are reported in all of the different systematic reviews. Some of these match, the ones that are highlighted in red match, but some of these that are reported in the systematic reviews don't match the drug label, and they don't match the other systematic reviews. So the bars in this figure here show the number of reviews that report each of the different harms. And as you get out to the right side of this bar chart, where we've got fewer and fewer reviews reporting those harms, we can see that there's more inconsistency about whether those are found in the different systematic reviews. Another way of saying this is that if all of the reviews don't report the same set of harms, some of them have to be wrong. Some of them are not reporting the full picture, or some of them are reporting harms that are not caused by the drug and that are not significantly or importantly different between the groups. So if we think about how we might improve the validity of harm information in systematic reviews, I've got a number of suggestions that come out of these results. One option would be to not include information about harms in systematic reviews of interventions for specific health problems. That is, when we divide up all of the information that we have about harms by different health problems, we find that the information is fragmented, and we're not pulling in information that appears in different reports about the drug that actually is applicable to the patients that are included in a given systematic review. A more sensible way of organizing systematic reviews about harms might be to follow regulators like FDA and to organize reviews about harms by the intervention, by the drug that we're interested in, rather than splitting that information up across different health problems. Another problem that we have when we think about harms is the way that we conceptualize core outcome sets, which inform the way we develop trials as well as systematic reviews. Like systematic reviews, core outcome sets so far have been developed for particular health problems. We say that across all of the drugs that are being used for a particular health problem, we think it's important to have some set of outcomes that are measured consistently. And that might make sense for benefits, but for harms, it might make sense to think about the interventions as our starting point rather than to think about the health problems as our starting point. For any trial of gabapentin, for example, we might say people should measure some set of harms that we believe might be associated with gabapentin rather than the health problems specifically that it's being used for. Additionally, we see that information from other data sources other than clinical trials or other than randomized clinical trials are not typically included in systematic reviews, particularly systematic reviews that are limited to a particular health problem. It would make sense in many cases to include information about harms that comes from preclinical studies, studies of similar interventions. Sometimes we might be interested in information that comes from computer modeling, other sorts of studies that would never be acceptable for information about benefits, but which might provide useful information about harms. And we might more broadly think about non-randomized studies as being important information sources for harms that need to be included in systematic reviews to supplement information sources that we use for information about benefits. We also find, particularly when we think about clinical trials, that the information in public data sources, particularly trial reports that we find in academic journals, contains very little information about harms. It's not a complete data source about harms. So if we're going to continue to do systematic reviews about harms, we really need to be thinking about using non-public data sources. And we should be considering systematic reviews that are limited to public data sources, particularly public data sources that include only randomized clinical trials, as being at serious risk of bias and at serious risk of reaching conclusions that aren't reliable and that won't be consistent with other systematic reviews or with information that we have from other data sources like regulators. So I will stop there. Here's my contact information. I'm happy to answer any questions that you have now. And if you have any questions that come up after we're done with the discussion today, you can reach me at the email address here. And I'm also on Twitter here. I see that a number of tweets have popped up, which I hope means people are already tweeting about this. And I'll be interested to see what you have to say when we finish. Thanks very much.
We have one question in chat from Daniela Consalves Bradley. How can one access non-public sources of data, Evan?
Great question, and one that's becoming, more and more complicated and by the day, I think. So in this case, Kay was an expert witness. Kay Dickerson was an expert witness in a patient litigation against the manufacturer of Gabapentin for mismarketing the drug. And we got access to those data by way of the litigation. I think, Tom, you were an expert witness in the same study, weren't you? Yeah. And in the quetiapine case, that also came out through litigation, though none of us were party to that. There are other ways that you can access some of that now. Manufacturers are sharing data about some clinical trials through various websites, like Vivly is a nonprofit group that works with a number of manufacturers to share data. You can get regulator reports from FDA, which are not quite as rich as some, but you can get reports from the Canadian regulators and from the European regulators, the European Medicines Agency. And for drugs that have been submitted to those regulators, you may also be able to get clinical study reports or CSRs, which are very rich data sources. But all of that is to do with recent studies. So for drugs and medical products that have been approved recently. For older trials, it's much more difficult to get them. And one of the things that we've pointed out in some of the work that we've published is that there is a real risk that some of this is going to be lost to history because it's in file drawers, and it's unlikely that we'll be able to access it and share it.
I think the next question is from Dr. Ann Holbrook at McMaster University, who says, agree completely that harms reporting in medication trials needs to systematically report harms predicted to be related to the drug, or go by drug rather than just focus on the disease. Has been difficult to make this point with the COMET initiative. Maybe you can explain to us what the COMET initiative is as well.
Sure. So COMET is, really the group that's interested in core outcome sets. It's an acronym that I'm sorry, I can't remember each of the words off the top of my head, but I believe the first two are core outcomes. And a core outcome set is a set of outcomes that are meant to be or recommended to be measured in all clinical trials and systematic reviews about a particular health problem. And that would, adopting core outcome sets will improve evidence synthesis and guidelines and patient decision-making, because we will be able to compare like with like and say which treatment or which intervention is best for people with a particular health problem. But most of the work that's been done there has been done with patients and providers organized around different health problems, and that's been very productive so far. But I think as Anne is suggesting, we need to think a bit more carefully about the harm side of the equation, whereas I think the benefit side of the equation has probably been better developed and has moved a bit further over the last 10 or 20 years that they've been operating.
Evan, I don't know if it's convenient for you to follow the chat if you'd like to handle the questions yourself, or would you like me to keep repeating them?
Easier for you to read while I'm talking, I suspect. So go ahead.
Wade,
Yes, and we need to have,
Dr. Wade,
we need to have them spoken out loud too for the recording. Sorry.
Oh, yes. Okay. Dr. Wade Thompson of our group is asking if one is interested in synthesizing data on harms in a systematic review, is it ever reasonable to use only observational studies for example, of routinely collected data?
It's an interesting question. I'm not sure why you wouldn't use the clinical trials, but in many cases, you're not going to get much information from clinical trials because you'll see a lot of events with, zero events in a lot of harms with 0 events in one group and 1 event in the other group, or 1 event in one group and 2 events in the other group. So for those things that might occur within the time for a clinical trial, there may be very few events. And then of course, there might be things that occur over longer periods of time where it would be sensible, I think, to look only at longer term studies. If the clinical trials are 8 weeks and you're interested in harms that occur after using an antidepressant for a year or 2 years, which would be a common period of time for somebody, to take an antidepressant, then it might make sense to, focus on the observational data there. But I would be hesitant to say don't look at the randomized trials, but I can easily imagine that they're going to be swamped by non-randomized evidence in many cases.
Randy Brills is asking whether, Evan, you have any recommended resources if one wanted to learn more about the topic you've discussed. And if you don't want to give them right now, we can probably post them in the edited version of the video, which will be online soon.
Sure. I mean, I'm happy to share the slides, and the slides include links to a number of the papers that we've written, which of course include lots of references to other people's work as well. And there has been a lot of good work in this area. I think in terms of kind of general resources, if you're interested in getting your hands on unpublished data about harms, there are a number of sites, including Vivly, Yoda, which is an initiative at Yale, and some others where manufacturers and others are making data about those things available. The Cochrane Adverse Event Group has some resources there, which I think are very helpful. There's a new extension to Consort for Harms, which will be coming out soon. And so at the trial level, I think that extension, when it comes out, and the references in that extension are also good. Good resources there. And I see that Riaz is also in the chat here. So in addition to me, Riaz and Kay and Tom, if you've got suggestions here for other resources, you're all experts in this too. So please do chime in.
Could we maybe we'll just skip quickly to Dr. Qureshi if you want to speak to your comment in the chat. Are we able to unmute Dr. Qureshi, Shipran? Riaz Qureshi?
Hi, folks. No, I think I was just, I think everything I said there agrees with what Evan said in response to sort of to Wade's question. I just was typing it out as he was answering a different question. Nothing else to really add, I don't think. Yeah, just, consider all the sources. I wouldn't discard, because you can get, trials have their own strengths when it comes to the evidence that they present, and I wouldn't discount that. Yeah.
Okay, Dr. Luis Paria is asking, how does one take advantage of this kind of systematic reviews of harms in pharmacovigilance? Or for regulators, industry, or health professionals, how should we be trying to use reviews?
So I think regulators are already doing some of this. And I think one of the things that we need to do is learn a bit more from the knowledge that's already in industry and in regulatory agencies, because they're already pulling in a lot of information from pharmacovigilance and non-randomized studies, and they're synthesizing information across different health problems. I think that particularly for newer drugs and newer studies where we've got information to all of these different data sources, it's clear that we need to take better advantage of non-public data sources and start looking beyond journal articles. And that's happening to some extent for benefits as well, because we're trying to address things like reporting bias with benefits as well. But the problem is much more profound, I think, for harms than it is for potential benefits. And an unfortunate side effect of that is I think it's going to be more time consuming to conduct reliable systematic reviews, and that the skills that are needed to use those data sources, particularly when it comes to surveillance data, for example, are going to be greater than the skills that it takes to just sum up some effect sizes from journal articles. So I think the implications of this are that we might get more detailed, more reliable systematic reviews for new interventions. It's going to take more time, resources, and more skill to do them. And I think that, there's already a lot of evidence that many systematic reviews are redundant and not very reliable. So maybe we will reduce the number of systematic reviews and hone in on better ones. I had another thought there too, but I've lost it. So go ahead.
We'll come to a related question in a minute, and maybe you can come back to it, Evan. Just before we do, I think the most remote person of all the people in the world is Aaron Nenninger, who's a academic detailing pharmacist in Terrace, British Columbia, which may not be as far from Vancouver, but quite hard to get to. Aaron asks, given the substantial issues you have shared with us, how should clinicians share with patients their potential risk for adverse effects, especially for newer medications? How should we make clinical decisions now while hoping for the systematic changes you're advocating to improve things in the future?
Yeah, I mean, this is related to what I was thinking, which is that, of course, you've got to operate with the best available evidence at the time that you're making a decision. And so that is going to come from a few different data sources. One will be systematic reviews and reports of clinical trials. But another will be information on the product labeling, so the drug label or the prescribing information. I think for newer products, it's going to get better. The trouble that we're going to have is that a lot of drugs that we use today have been around for a long time. Gabapentin was approved 25 years ago, and it's still a very, very widely prescribed drug. There are millions of prescriptions that are written every year. So we're going to have to balance not only the different kinds of information that we have about new drugs versus old drugs, but we're going to have to think about how we interpret the new drugs versus the old drugs when we've got much more information about the new ones and maybe less biased information about the new ones. For my money, I would say the prescribing information is probably more comprehensive in the number of different effects that you might see as a consequence of taking a drug. Where it's limited is that you often don't get effect sizes or the probability that you're going to experience an event or the severity of that event. So they tend to name a lot of different events, but you don't know whether you're twice as likely or your risk is increased by 25%. You just don't know much about the effect size, which is what we would hope to establish through systematic reviews and meta-analyses. So you have to read both kinds of sources with a grain of salt. The systematic reviews are not very complete, and their data sources, the prescribing information probably is more complete in the data sources that the regulators have used, but it's less complete sometimes in what's being reported that you might be interested in as a clinician.
There's another question very dear to my heart from British Columbia, from Sirisha Asuri and Victoria, saying, many of us depend on good systematic reviews for our own use, but more and more there are examples of reviews that are not up to the mark. Is there a place we could have reviews validated? Anything to look for on reviews for their quality and reliability? And Carol will note that I was suggesting we might do a methods webinar in the future about the quality of Cochrane reviews and how best to use them. So what are your thoughts on that, quality of reviews?
Well, I mean, Cochrane's been mentioned a few times. So for anybody who isn't familiar with Cochrane is one of the main producers of systematic reviews, and Cochrane reviews do need to meet some minimum criteria for their methods and and reporting. So they tend to be a very good source of information about systematic reviews. There are some limitations in certain Cochrane reviews as well, and we've written about some of those, but by and large, Cochrane is a reliable source of systematic reviews. There are a number of different tools that are available for assessing the quality of systematic reviews. I suspect Carol and others know more about the current best methods for that than I do. AmStar is commonly used, and there are a number of other checklists, including the CASP checklists that are used at Oxford and some others. But Carol, do you want to add anything about assessing systematic reviews? You do a lot of this.
Yeah, so there's two main tools that people could use to assess the quality. For the quality, there's the AmStar 2 tool, and that can be found online. That is by Bev Shea, who's the main primary investigator for that. And then there's also the Robust tool, which is a tool to assess the biases in systematic reviews. So they're very different. One has, the AmStar 2 has like more conduct, some reporting questions, but the Robust tool is focused primarily on addressing the biases within a systematic review, which can include, we all know publication bias, where, Evan was talking about this, where unpublished studies are not included in that review. And then we don't, because those unpublished studies aren't in there, we don't necessarily know what the true effect of the intervention is. So I can put those in the chat in a minute.
Evan, I've got, Carol has allowed me as a moderator to ask one question. A problem which has plagued our group in the Therapeutics Initiative for over 20 years is whether serious adverse events are as bad as we think they are. And we ended up using them as a surrogate for serious morbidity and insisting that they ranked in a hierarchy of outcomes after death, second only to death. I haven't personally encountered anyone who agrees with our approach, and we've had some local people who disagreed strongly, saying you don't understand the purpose of recording serious adverse events. Do you have any thoughts on that?
Well, if what you get is the name of an event, it's very difficult to know how important it was. And that's often how these things are assessed and reported. The tricky bit of looking at a journal article, for example, is that you just don't know. The case report form might include, rich detail about what actually happened to a person. So if you see, a report of suicidality, which came up in some studies in which Peter Gauch's group has done some work on, that might be somebody who responds to a clinician and says, sometimes I think about killing myself. And that would not be very uncommon for somebody who's severely depressed. But the term suicidality could also, lump together things like I made a serious attempt, or I've got an active plan to end my life. And those are much more serious. And very life-threatening. So without knowing more than we usually know, looking at a journal article, or even looking at the information that we have in a cleaned database, I think any particular event could run the gamut from barely over what we think of as a serious adverse event, just that it requires some medical attention, and maybe that's not that important to a patient, to something that is, potentially long-lasting, causing permanent impairment or life-threatening. So I think, I'd make a point that kind of sums up my view of not just the serious adverse events, but also things that we might expect in general, which is that it's better to assess things systematically. If we know that there are particular harms that are going to be associated with a drug or a class of medications, And we're going to want to compare different medicines to see which of them is potentially better for a certain group of people. We should be assessing those harms systematically across trials so that we don't have to do this guesswork at the end, and we can make those comparisons.
All right, well, I wanted to just wrap up here. We're just a minute past the hour, and thank you, Dr. Evan Mayo-Wilson, for an amazing presentation, and Dr. Tom Perry for facilitating the questions, and Ciprian for helping us with the evaluation. And I hope we see you next time, at the end of next month.
Thank you all.